Welcome to this joint webinar, Patient Involvement in HTA in the Asia region, which is hosted by HTAsiaLink and Health Technology Assessment International, or HTAi. I'm Anne Single, the Vice President of HTAi. I'm joining today from Brisbane, Australia, so I begin by acknowledging the Yagara and the Turrbal, who are the traditional custodians of this land. I want to pay my respects to their elders, past, present, and emerging, and pay my respects to any First Nations people or elders joining us today online. I'm pleased to share that I'm the first HTA Vice President from the patient sector, which shows how important today's topic is to the whole HTA community. HTAi is proud to undertake this webinar with HTAsiaLink as part of our Memorandum of Understanding to support our shared commitment to information exchange and collaboration in HTA across Asia. Today, we've got a jam-packed agenda. We're going to hear from 5 very experienced people from the region who'll give you an overview of patient involvement in HTA and offer 4 case studies from different perspectives. We'll have time for a little bit of discussion, but the agenda is so tight. So please add your questions to the chat and our speakers will also try to answer them there as well as on screen. We're also a big group, so feel free to introduce yourselves in the chat, perhaps share where you're from or where you're based. And to get started, we're actually going to have 2 polls, so we have a sense of who we're talking to. And I'm asking Nicola if he can start the first poll. And the first poll is actually one which asks you if you can just describe yourself. So just to give us a sense of who we're talking to here. Are you a patient, family or friend of a patient or carer, patient organisation, HTA body, biopharma or life sciences? And we've got others down the bottom. If you're another, please feel free to add in the chat what that other is so we can learn more about who's come. And when we've got a fair number of replies, Nicola, we can share that outcome so everyone can see who's online with us today. Oh, we've got a great range. Okay, so we've got some family and friends, we've got some patient organisations, we've got HTA bodies, we've got people from biopharma and life sciences, government, research and other. So those 5 people who are other, we'd love to know in the chat what sort of other you are. Welcome everybody. And now I want to launch a second poll, which is one which just is to find out what you know about HTA, really, this health technology assessment word that we throw around. So we just want to know, do you know what health technology assessment is? And you can either strongly agree, disagree, not sure, agree or strongly agree. Sorry, I think I said that incorrectly. Let me say it again. The first option, strongly agree. You really do know what HTA is all about. Sorry, I've done it again. You don't know what HTA about. This is funny. Okay, so number 1, you don't know what HTA is about, strongly disagree, disagree, not sure, agree, strongly agree. I hope I haven't confused you too much there. But don't worry if you don't know that much about health technology assessment, because Fiona Pearce is coming up and she's going to help explain it much more clearly. Can we see the results of that poll? Oh, good on you for sticking with that poll after that introduction to it. So we've got a real range of knowledge there. That's terrific. We hope by the end of this, regardless of your knowledge of health technology assessment, you've learned something new and you've made some new connections as well. Okay, so may I hand over to our first speaker, Fiona Pearce. Fiona is from Singapore's Agency for Care and Effectiveness, and she's also the co-chair of HTAi's Patient and Citizen Involvement in HTA Interest Group. Welcome, Fiona.
Thanks, Anne. I'll just bring my slides up. Hope everyone can hear me clearly. All right, let's put this into presentation mode. Thank you so much to HTAi and to HTAsiaLink for organising this joint webinar today and for having me here to speak, and also to Anne for moderating this really important session. Before we hear the case studies from across the region, I thought I'd briefly describe the principles of health technology assessment and the ways in which patients and caregivers can be included in the process to strengthen healthcare decision-making and health policy development. From Anne's poll earlier, I can see that many of you are already quite familiar or somewhat familiar with health technology assessment, or HTA as it's commonly referred to, and I'm going to use that term for the rest of this presentation just because it's simpler. But for those of you who are new to this area, the first thing to understand is that it's not all about technology like computers and smartphones. The technology we're referring to here is a health technology. It's a medical intervention. So it could be anything like medicines, vaccines, gene therapies, or even surgical procedures like a hip replacement, or a medical device like a scan or a finger prick test for blood glucose monitoring. Governments can't financially support every new health technology that comes onto the market, and that's just because of limited healthcare resources and the budget constraints. But also, new health technologies are not always better than existing ones, and they're usually more expensive. So whenever a new health technology is introduced, it might be necessary to stop or reduce funding something that is already being used. And to ensure that these funding decisions are fair and consistent and supported by reliable evidence, we use health technology assessment. So this method essentially collates and analyzes information about the clinical, social, economic, and sometimes even ethical issues related to the use of the health technology to understand its benefits or clinical effectiveness, as it's often referred to, also the harms and the costs compared to alternative options or the existing standard of care that's being used, the new health technology might replace. So to put simply, HTA balances the cost of the health technology against the benefits it brings to patient care and helps us identify which patients are most likely to benefit if the health technology is funded. And down the bottom of this slide, I have the formal definition here that you can see is quite wordy, but I've just provided a quick overview for you today. Now, the methods and processes of HTA can differ across each country, but the type of evidence that informs the assessment usually includes a literature review of the clinical and economic evidence, cost information for the health technology under evaluation, but also for the alternatives that it's being compared to, as well as expert opinions from patients and clinicians about local clinical practice and lived experiences of the medical conditions and treatments. Sometimes economic models are developed for cost-effectiveness analyses and budget impact simulations to estimate the long-term benefits and costs of the health technology when used by the local population. And all of this information is collated into what is known as an HTA report. And this is then used to inform funding recommendations by decision makers. There are different ways that patients can be included in the HTA process, but before we look at this, I think it's important to address the question of why we should be including patients in HTA. It's not about being inclusive or doing the right thing. It's about doing better research. So when we involve patients and families in healthcare decision-making, we're able to better address their health outcomes and improve the health of the population. Involving patients in HTA improves the relevance of the assessment. Patients have knowledge, perspectives, and experiences that are unique and contribute essential evidence. It also improves the legitimacy of the funding decisions that result from the HTA. It enables those most affected by those HTA decisions to participate in the process, contributing to transparency, accountability, and credibility of decisions made. From a procedural perspective, we need to also consider fairness as well. Patients have the same rights to contribute to the HTA process as other stakeholders, and there should be processes in place that enable effective engagement. Lastly, there's capacity building. Patient involvement processes address barriers to including patients in HTA and build capacity for patients and HTA organisations to work together. In HTA, there are two distinct but complementary approaches to involve patients. The first is formal participation during the process. So this can be including patients as part of decision-making committees, or it could be consulting patients on different aspects of an HTA, co-designing processes with them, or even inviting them to submit evidence that's included as part of that HTA report. The other way that patients can be involved is through research to capture patient-related experiences with healthcare and patients' preferences that can be considered alongside the clinical and economic evidence in the HTA. I'll go into the types of patient experience data in a few slides, but first I think it's helpful to note that how you actually involve patients goes across a spectrum of engagement and it differs widely across countries. So I've got this ladder picture here, and you can see at the very least at the bottom rung, we can inform patients. When we inform patients, we tell them what we're doing and we give them information that they might need. Going up the ladder next is consult. This is when a preliminary decision might have been made and draft processes have been formulated already. And we ask patients to provide feedback, which may or may not be taken into consideration. The next rung up, we might start to actually involve patients in the process. They might be able to participate in decision-making discussions or expert panels, or submit evidence to inform the HTA. Next is collaborate. That's when patients help develop processes and methods. They drive acceptance and awareness of the HTA work. They might even be involved in data analysis. And finally, at the top rung is empower, where patients become key decision makers. And this is something that I know many of us here today are aspiring to achieve in our different healthcare systems. On the right side of this slide, I've listed 3 principles that we can use to guide meaningful patient involvement. There are, of course, many other factors to consider, but I just wanted to highlight these 3 today because I think they're quite important. The first is non-hierarchical thinking, and this can be particularly challenging in the Asia Pacific due to existing cultural practices where patients are often passive recipients of healthcare, and clinicians hold most of the decision-making powers about their treatment options. It's important to recognize that one perspective is not more or less important than another. They're just different lenses on the same problem that we're working together to solve. The next principle is authenticity. Patients usually know that they're being used as a checklist item. So it's important to approach any patient engagement appreciating and valuing the expert opinion that patients bring to the table through their vulnerability and their situated knowledge. Finally, I've put openness here. It's important to be open and receptive to these critical perspectives. It improves the quality of HTA and improves our understanding of patients' needs, expectations and preferences, and it helps us to equitably address the concerns of the patient population we're serving. We need to be open to the critical perspectives and not just the perspectives that we want to hear. With today's technological advancements, there is a lot that we can tell about a patient already without even talking to them. So whether that's through diagnostic tests or reviewing their medical records. However, unless patients are asked about what is important to them and how they rate their quality of life and experiences of healthcare, we don't know the whole picture. That's why patient experience data plays an important role in strengthening the traditional evidence base used in HTAs. This data can be grouped into 2 categories. The first one is patient-reported experience measures. So that's PREMS as an acronym, and that captures patients' perceptions of their experience with healthcare or services being used. The other is patient-reported outcome measures or PROMs, which capture patients' perspectives about how a medical condition or the care they receive impacts on their health and well-being. These data can be collected by an individual or an organisation and help identify unmet needs and treatment preferences of patients, the benefits and possible disadvantages of current treatments they're receiving, and their expectations of any new treatments coming to market for their condition. Importantly, the data can also help determine if the outcomes measured in clinical trials or economic models are relevant to local patients in the local setting, and they can potentially fill gaps or address uncertainties in the scientific evidence. They can also identify if there are any issues affecting a patient's ability to use or access treatments as well. In most instances, patients' experience data are collected through surveys, And this can be done as research in academic settings, or it can be done by the HTA evaluators during the course of their assessment. It does differ across jurisdictions, but in Singapore, where I work, some of the typical questions that patients or their caregivers may be asked to inform an HTA are here on this slide. So in Singapore, each survey is tailored to ask specific questions related to the condition and the technology under evaluation to help address evidence gaps that technical staff have identified as they're doing their HTA. But typically there are core questions, and these include how the condition affects patients' daily lives and quality of life, the impact on carers, experiences with current treatments, and expectations for any new treatments. This information is then collated and included in the HTA report to present to the decision-making committees. So in the interest of time, I just wanted to finish off by sharing a few useful resources that have been developed in Singapore, which might serve as useful references or sources of information for other jurisdictions that might be starting to implement patient involvement opportunities in their HTA work. All these documents are available on ACE's website, and they're living documents, so they're regularly updated as processes evolved in line with feedback from patients and patient organisations. There are also a series of learning modules on different aspects of HTA that are currently in development to help with self-directed learning capacity building for anyone that's interested. So I think I'll stop there, Anne, to allow any questions. Thanks very much.
Thanks so much, Fiona. Now, I notice we haven't got any questions yet in the Q&A box. Do feel free to add your questions there just to help us, because we've got a lot of presentations today. But Mayong, I can see your I've scared our question askers away. But yes, please, questions in the Q&A box, and any problems putting them into the Q&A box, do put up your hand and we'll take them from you verbally. But what I'll do, Fiona, is I actually think I'll go on to the next speaker and give people a chance to put those questions in the Q&A. And do you mind if I circle back and ask you further questions as we go along? Because that was a huge overview of that within about 10 minutes, and it was really helpful.
No problem at all. Thanks, Sam.
Great. So now let's get into these case studies. From the Malaysian Health Technology Assessment section, I'm delighted to welcome Senior Principal Assistant Director Nur Farhana Mohamad. Welcome, Nur.
Thank you, Anne. Okay, can everybody see the slide?
That's perfect, thank you.
All right. Okay, good morning, good afternoon, and good evening to everyone, depending on where you are right now. So first of all, I would like to thank HTAi and also HTAsiaLink for giving me this opportunity to speak at this first ever joint webinar. My name is Nur Farhana, and I'm from the Patient Public Involvement in HTA team at Malaysian Health Technology Assessment Section, MaHTAS Medical Development Division, Ministry of Health, Malaysia. So today I am very delighted to share our journey in incorporating patients' voices into the decision-making through HTA in Malaysia. So I will begin my presentation on just the background information about the Malaysian healthcare system and MaHTAS role, and then we'll go into the key examples of our work and also the future direction of PPI in Malaysia. All right, so Malaysia is a vibrant and multi-ethnic country. We are located at the central of the Southeast Asia. Our population is about 34.1 million in 2024, and the life expectancy in Malaysia has improved to about 73 years in male and about 77 years for female. Our GDP per capita is around 11,700 USD in 2023. So this is the overview of the Malaysian health system. Our healthcare system is a dual-tiered system. It's comprised of the public and the private sectors. So the public system is heavily subsidized by the government. So this is to ensure the accessibility and also the affordability for the population, while the private sectors covers more on the specialized care and also the personalized care. So as other countries are facing. We're also facing challenges of increasing NCDs and also the rapid evolution of the health technologies. So this is the backdrop against which MaHTAS operates and stands. So we provide evidence-based inputs to shape healthcare policies and decisions for more sustainable and equitable healthcare system in Malaysia. So MaHTAS was established in August 1995. So we are actually a section under Medical Development Division, Ministry of Health. We are quite small with about 35 reviewers and 6 information specialists, and the rest are all the admin staff. We provide input for decision and policies related to health technologies. We evaluate a wide range of health technologies, including medical devices, pharmaceuticals, public health interventions, and even the traditional and complementary medicine. So it is actually everything under the sun. So our work informs policies, clinical guidelines, and decisions on resource allocation. So at MaHTAS, we are involved in every stage of the technology life cycle. So we can see here in the illustration that we involve from the horizon scanning, which is the involving the health technologies that are not yet marketed, to HTA evaluation and also clinical practice guidelines. And our HTAs informs various decisions related to health technologies. So this includes procurement decisions. The HTA also helping to evaluate whether new technologies should be adopted or not in the Ministry of Health facilities. They also provide evidence for service provision planning, designing of the benefit package, reimbursement, and also pricing strategies. And beyond that, HTA also help identify best practices in the clinical setting and support decision on whether to disinvest in technologies that are no longer effective or relevant in the healthcare. So in Ministry of Health Malaysia, for technologies costing more than RM200,000, HTA is mandatory. So this is to ensure evidence-based decision-making in Ministry of Health Malaysia. So in Malaysia, the healthcare decision-making related to the HTA involves these 3 key groups. So the first group is the expert committee members. The second is the HTA Technical Advisory Committee. And also the third one is the HTA CPG Council. For the expert committee members, including HTA experts, clinicians, academicians, and patient representatives. So they provide technical insights as well as the patient perspectives for selected HTA projects. And the next group, which is the HTA-PAC members, ensures the recommendations are scientifically robust and also aligned with our priorities. The next council, which is the HTA-CPG Council, chaired by the Director General of Health, integrates inputs from diverse stakeholders, and this includes a patient representative from a patient groups coalition named Suara Kita. So if we translate that, it will be our voice, to endorse recommendations on health technologies, whether for adoption, further research, or not recommended. So as mentioned by Fiona previously, involving patients in the HTA process adds great value because patients have unique experience, knowledge, and perspectives. They know how to live with the disease. They know the hurdles, the problems surrounding the health technology assessment, surrounding the health technology, and what better would mean for them in terms of patient-relevant outcomes, some broader issues around the health technology, disease, and treatment. So patient involvement ensures that decisions are more transparent, accountable, and also aligned with the societal priorities. For example, patients can highlight barriers in adopting the new health technology that we assess, but they also can suggest practical ways to improve its implementation. So this adapted from publication by Abelson J. et al. In 2016 on PPI in HTA, a framework for action. So this illustrates where and when can patient be involved in HTA, as also mentioned by Fiona previously. So patient can contribute to HTA at various stages. For example, during topic selection and during scoping phase, their perspectives can help prioritize the most relevant issues. And also when evidence collection, patient input can highlight the real world challenges and also the benefits or barriers of certain technologies that we assess in HTA agency. Incorporating patient voices also improves the quality of the recommendation, and it ensures transparency and as well as legitimacy in the final decisions by the HTA bodies. So this ultimately lead to increased awareness and trust in HTA process among the public and patients. So in Malaysia, MaHTAS has gradually involved patients at various stages of HTA process as indicated here. So we have included patients in evidence collection, drafting recommendations, professional consultations, as well as post-review feedback. So now I'm going to walk you through MaHTAS' journey and experiences in incorporating patients' voices into the HTA process. So I'm going to highlight some key initiatives and their impact. So in Malaysia, patient involvement in HTA started at around 2009. We have engaged patients as expert committee members in specific assessment, including the HTA of prostate cancer screening in 2010, and also the HTA of computerized cognitive behavioral therapy for adults with depression in 2011. And then more recently, we've expanded our efforts to include patients in the clinical practice guideline development and steering committees. So our early involvement for PPI in HTA and also in CPG are described in this publication that you can access online. We have also joined INATA Patient Engagement Learning Group in 2019 and we also joined activities by HTAi PCIG. In 2022, we have included representatives from various patient organizations to help us in development of MCDA for rare disease reimbursement prioritization in Malaysia. You can also read more about this in our recent publication about MCDA in HTAi journal. So this is one of the HTAs that we've included patient perspective. The pre-dialysis education program, or PDEP, was assessed by HTA to address the significant issue of unplanned dialysis among CKD patients in Malaysia. So as we are all aware, unplanned dialysis are associated with increased patient morbidity, mortality, as well as hospitalization, which highlighted the urgent need of the structured PDEP in Malaysia. So this HTA has been done to review the available evidence and feasibility of structured PDEP before its adoption into a national program in Malaysia. So in this HTA, patients were actively involved in the process through the local survey conducted in January 2020. So this survey engaged patients, caregivers, as well as the healthcare workers to understand their experiences and gather their feedback on the design and delivery of the program. So the findings highlighted some key suggestions, which included the need for an individualized approach, a strong support system, adequate staff training, as well as comprehensive educational content tailored to the stage of CKD and the emotional as well as psychosocial needs of the patients in Malaysia. So the involvement of the patients in the HTA has led to actionable recommendations as outlined here. HTA PDEP recommended for a standardized approach to PDEP with a multidisciplinary team and also using mixed education delivery styles, including individual and group sessions supported by interactive materials and also personalized content addressing the specific needs of patients and caregivers, emphasizing the emotional and psychosocial support. So the impacts from this HTA PDEP were immense. PDEP has seen be expanded nationwide in the MOH hospitals with the launch of the PDEP My Buah Pinggang, or we translated it to My Kidney in English, portal in 2022, and the introduction of the Kidney Ambassador Initiative. So these changes reflect how patient involvement has not only improved the relevance and quality of the program, but also enhanced patient outcomes, ensuring better preparation for dialysis decisions among CKD patients in Malaysia. Another key example of patient involvement is our HTA on continuous glucose monitoring system, CGMS, for insulin requiring diabetes patients. So this technology has represented a significant advancement in the diabetes management because it provides real-time, non-invasive glucose tracking. So to assess the feasibility and potential adoption of CGMS in Malaysia, MaHTAS has conducted a comprehensive HTA that has included a qualitative study to capture patients' perspective. So the qualitative study used focus group discussions, FGD, to explore the experiences, challenges, as well as expectations of the CGMS users and their caregivers. So we have selected participants from the diabetes clinics as well as from the patient organization. Discussions guided by semi-structured questions focusing on the benefits, barriers, and expectations, and then were recorded for analysis. So these are the steps taken for the FTD. The study began with a scoping review to identify evidence gaps and refine objectives. And this was followed by the planning where objectives and criteria as well as timelines were outlined. And then a proposal was prepared and approved by the Malaysian Research Ethics Committee, MREC. And then we proceed to engagement with clinicians, patient groups, and diabetes societies to facilitate recruitment of the patients and caregivers. FGD was then conducted from May and September last year using purposive sampling, and data was transcribed, coded, and analyzed to extract the key findings. So these are the results from the FGD. So the FGDs reveal several key findings. Patients and caregivers highlighted in their own words the medical, emotional, and social benefits of CGMS, such as improved quality of life, better quality control, but they also shared barriers like cost, skin irritation, and limited accessibility. And despite all that barrier, both diabetes patients and caregivers have overwhelmingly positive attitude towards the utilization of CGMS, and they strongly endorse the use of CGMS in diabetes, particularly the type 1 diabetes and those at high risk of hypoglycemia. And besides that, they also emphasize the need to address the financial barriers, the access issues, the technical supports, as well as the patient support groups, as well as training for healthcare providers to improve diabetes care plans in Malaysia. So these insights were integrated along with the results from systematic reviews and local economic evaluations. So this has informed a consensus recommendation to offer CGMS to specific groups, particularly the insulin-requiring type 1DM patients at high risk of severe hypoglycemic events. And following this HTA, the findings have supported the adoption of CGMS in the clinical practice and its reimbursement for the selected patients through medical fund of the Ministry of Health as recommended by our HTA. So here's a snapshot of our MaHTAS PPI team hard work engaging with clinicians, patients, and caregivers during the focus group discussions. It was actually truly insightful to hear their first-hand experience with CGMS. These are the additional activities demonstrating our commitment in ensuring patients' voices are heard in the healthcare decision-making through HTA in Ministry of Health Malaysia. So since November last year, we have included a representative from Suara Kita, which is a coalition of patient advocacy groups in the HTA CTG Council. And so this council ensures patient views are central to the health technology decisions before implementation. We also successfully conducted a pre-conference workshop last year, organized jointly by the HTAi, PCIG, and MaHTAS. So at that time, we engaged stakeholders from HTAsiaLink network and patient organizations. Additionally, we have submitted a manuscript on our work in HTA CGMS to the International Journal of Technology Assessment in Healthcare, and this is currently under revision, and we hope to see it published soon. And of course, all of these efforts are not without challenges. So these are some of the key obstacles that we face during involving patients in our HTA. This includes limited awareness of HTA among patients, patient organizations, as well as the decision makers, and coupled with constraint in time, resource, and capacity. But looking ahead, we want to expand patient representation in HTA priority setting next year. And we also want to ensure diverse groups are included and build capacity for stakeholders to effectively participate. And also we'll be planning on evaluation of the impact of the patient involvement for HTA in Malaysia. So in conclusion, integrating patient voices into HTA enhance the relevance, transparency, and impact of healthcare decisions, especially for Malaysia. So by aligning our policies with patient needs, we can ensure better outcomes and build more inclusive healthcare system, because after all, nothing about patients is without patients. So with that, I thank you. Thank you very much.
Oh, thank you so much, Noor. That presentation was so rich with really interesting examples. We've got questions flooding in, and I'm just going to come to one quickly to you, and I'm encouraging all the panelists to look at the questions in the Q&A, because we'd love you to answer what you can there. I was thinking earlier about Fiona talking about hierarchy, and that can be very important in this region. How does MaHTAS ensure a balance between technical, clinical, and patient-centered perspectives in its HTA recommendations?
All right. I'm sure this is a challenge faced by many HTA agencies, not just MaHTAS, in terms of balancing technical evidence, clinical priorities, as well as patient-centered perspective to ensure the comprehensive recommendation. So at MaHTAS, we achieve this balance by involving all stakeholders in the various stages of the HTA process. So we've included clinicians, HTA experts, researchers, policymakers, and patients, a patient organization at different stages of HTA process. For example, in HTA CGMS, the clinicians and the HTA experts, we provide the evidence in terms of the clinical effectiveness, while the patients highlighted the real-world evidence, the real-world challenges like cost, usability. So this has led to recommendations that address both clinical and also the patient needs. So this has resulted into the targeted subsidies for the high-risk patients.
Oh, thank you. That's a very useful answer. It's one that comes up a lot. I can see more questions appearing for you in the chat, so I know you'll have a look at those. And so now thank you so much. And now I'm going to pop back to Singapore, because we're going to hear from Candy Gan. Candy is a passionate type 1 diabetes advocate, and she's even co-authored Singapore's first bilingual children's picture book on the condition. Welcome, Candy.
Hello, hi everyone. Okay, thank you so much, Anne. So hi everyone, I'm Candy from Singapore. And first off, I want to thank our first speaker for sharing from the evaluator's perspective on CGM evaluations, because I'm coming from the opposite end. And it's really wonderful to hear that our neighbor is doing similar brilliant work.
Thank you.
So a bit more about the background of type 1 diabetes, because that is the condition that I live with. It is a chronic autoimmune condition where the body does not produce insulin naturally, because our immune system has destroyed the insulin-producing beta cells. And that is why we have to take insulin externally, either through multiple daily injections or an insulin pump. And this also means that oral medications do not work. Now, type 1 can be diagnosed at any age, but it's more common between 4 to 7 or 10 to 14 years old. And it's important here for me to say that type 1 is not caused by diet or lifestyle decisions. So you can think of it like you're an automatic car where your pancreas manages your blood glucose levels for you, and I am the manual car. Now, keeping our glucose levels in range is actually quite hard work. From carb counting to managing our insulin dosages, which change daily, by the way. And we also face things like judgment and stigma from those around us. And some of us even change the clothing and travel decisions we make because of the devices that we choose to wear. And all of this takes a toll. So what you see on screen are just some factors from a local study done by doctors from the Singapore General Hospital on self-care burdens. These are all of the invisible parts of type 1 diabetes. And to illustrate what these burdens mean, a Stanford study found that type 1s make 180 more decisions every day. And that roughly translates to one decision every 5 waking minutes. But what are we all thinking about? Well, there are 42 factors affecting blood glucose levels, and these can come in at any point in our days. So you might be surprised to see that actually less than 25% of these factors are food-related. And these decisions follow us through every stage of our life. the younger we are diagnosed, actually, the more we will have to learn to live with this condition as we battle things like going to school, moving overseas for education, starting new jobs, going through different life stages like pregnancy and menopause. So this is what living with type 1 looks like for me. I've had it for 26 years now, and in total, I've used 62,500 needles on myself. And 75% of these are for checking my glucose levels, and the other 25 is to give myself insulin. And these needles actually exclude the HbA1c tests and the lab tests that I still will need to do when I go for my regular checkups. Now, for 16 of these years, I did 3 to 5 injections every single day to manage my glucose levels. And when I entered university, I started using an insulin pump. So you can see some of the supplies in the photos here. And it's a lonely journey if you don't have a community. Currently, I am one of 5 volunteer admins managing Singapore's only community group for type 1 diabetes. We are an independent group. And to date, there's almost 530 patients and their support network within this group. It's a closed Facebook group. Now, we represent the platform trying to vocalize, localize, and normalize the experiences of the T1 community through events, peer support, and advocacy. Now, between 2023 and 2024, we contributed to the Ministry of Health's technical evaluation of continuous glucose monitoring devices and also worked with them to co-develop the patient educational material. Now, for those who may not be very familiar with CGMs, they are wearable technology used to monitor blood glucose levels without the need of finger pricks. And real-time CGMs transmit the glucose data from the transmitter to users like myself with smartphones. Oh, actually, I hope you can see it. I'm actually wearing the CGM now. It's the exact one that has just got subsidized this year. So yes, very exciting for me. Right. So the data that is shared with our phones can also be further shared with our healthcare professional team, and this is enabled through cloud technology. And our loved ones can also see it if we want. Now, I won't go through so much of the technical details more, but if you're interested, you can also find out like the eligibility criteria and the exclusions on the Agency for Care Effectiveness website. And Fiona mentioned that a bit earlier. But why I'm here is to actually tell you how we contributed. So, starting from a timeline. Back in 2017, an application was put in by clinicians to the Ministry of Health to consider subsidizing insulin pumps and CGMs. And then we fast forward to 2023, last year. MOH was ready to engage the patient groups, and they sent us an invitation to fill in lived experience surveys. And that lasted about 1 month, where we sent everything in. Then fast forward to December of last year, where the CGM subsidy was approved by the Ministry of Health's Medical Technology Advisory Committee. Then, what it means is that starting from this year in May, that's when the subsidy officially commences, where patients in all public hospitals in Singapore can benefit from this. Then we received an email shortly after to co-create the patient fact sheet, which is an introductory online PDF, which introduces what CGMs are about, how they are different to manual finger pricks, and it's really for the new or potential users of CGMs to understand what they can consider in their diabetes management. Now, we're going deeper into the lived experience surveys conducted. Thank you to Fiona's team for sharing this breakdown as well. In total, there were 96 surveys that were received by Fiona's and the ACE team. Now, our group formed the largest contribution, amounting to almost 70% of the surveys received. And for some of you who work more in the type 1 diabetes space, you can appreciate that for a small community, this was a really loud voice. Now, what was the composition of our surveys? Well, the breakdown is as follows. There's actually almost an equal split between the patients themselves and the caregivers. And there's also a small proportion from school teachers as well, because I personally invited them through some parents who had a good relationship with the teachers, given that young kids are very much cared for during school hours by these professionals. And there were 5 key themes that stood out from our group survey responses. The financial cost, the social stigma of living with type 1 diabetes, caregiver stress, and this is as 24/7 as the condition affects the patients themselves. All of us also want more peace of mind and convenience, and we also wanted to have more information on how to live as normally as possible with type 1 diabetes. Now, what's often swept under the carpet is the impact of this condition in all areas of our lives. So you can see here in the third bubble that there's one parent's feedback about their child having school refusal issues, which took a heavy toll on their family. And even the wife stopped working. So you can imagine that her departure from the labor force bears a real productivity loss to our economy. Just imagine how many other people could be contemplating the same thing. Now, you've heard from Fiona what HTA is, and now here's what it has done for our community. Assuming you are a 60 kg adult using diabetes technology, before 2019, your monthly cost of managing type 1, if you're using the Dexcom CGM and you're doing manual insulin injections, will be around $435 per month. And this does not include costs like using an insulin pump or costs of your doctor's appointments and lab tests, etc. Now, move to 2020, your monthly cost will have been reduced by between 8 to 22%, depending on the means tested subsidies, ranging from 30 to 80%. Now, this is linked to per capita household income in Singapore. And this year, 2024, the cost of managing diabetes has been reduced even more with the CGM subsidy. Actually, taking into account all the subsidies available now for pump and CGM, the Ministry of Health has reduced the cost of type 1 by up to 74%. But the longer-term impact of these subsidies is how they give us more flexibility in our daily lives and helps us make better decisions when managing our condition. And these are the benefits that should be factored into HTA analyses, and why I put it together on this slide, together with the cost savings. Now, for myself and many others, being able to afford CGMs mean that many of these hidden costs linked to type 1 can finally be addressed. And as you can see, technology is really not a luxury for us. So it's been 7 months now. And what I did before this webinar was a quick survey this month to gather feedback from some of the new CGM users. So there were 40 people in total that responded. All of them have benefited from the subsidized CGM. Now, these were some of the questions that they answered. So respondents reported that doing finger pricks was relatively difficult in the first graph. But few of them reported that it was extremely difficult. Now, in the second graph, they also said that the subsidized CGM significantly helped improve their T1 management. Now, looking at these, you might already be asking, Why is it that only 23% of respondents found traditional finger pricking very challenging, yet all respondents, except for one person, voted that CGMs helped them tremendously? So to answer and better understand the user experience, it's down to what question we ask. So notice that I left the second question before quite open. So here they chose all the ways that they felt the CGM helped them. Now, the results here are actually not very surprising to me because I felt the same pain that the respondents have using needles on a daily basis. So while cost savings is not the top upvoted reason, the subsidy actually enabled more people to access this technology. And one user pointed out that they have been able to reinvest their savings into other diabetes equipment, like insulin pumps, and this all empowered him even more in his type 1 management. And this is in the first speech bubble at the top. The most important benefits to us, though, are the top two reasons that you see right at the bottom here. Firstly, CGMs allow us to see our trends throughout the day, which already reduces the never-ending concerns around how our glucose levels are being affected by our activities and hormones. And secondly, we are better equipped to make all of the dosage or adjustment decisions we need without having to draw blood each time. And I often say that the harder part is not the blood or the pain, because to be honest, we don't feel it after a while. And just like a marathon, it's the accumulation of the silent mental burdens that each of us push through every day, which is the harder part. But it doesn't stop here. The partnership needs to continue on with the HTA evaluators and implementers. So remember the fact sheet that I mentioned. We gave extensive comments on it, and this itself was already a successful example of the partnership that we have built. Now it takes two hands to clap. So for us, this meant that our group giving suggestions actually helped the ACE team understand our lived experiences, while the ACE team members provided replies to each of our comments. And I'm stressing this because it might sound like a time-consuming task, but actually it is very important in building the necessary trust with a patient group like myself and many others. So the feedback loop that was created actually fostered mutual respect because it gave my group the reassurance that the government was really listening to us. Now, this fact sheet took about 2 months to make, but it was worth it because now it is something that I am fully prepared to support and advocate amongst my community members. So, what I'm trying to say here is that the user community will help you not only obtain, but sustain the outreach and knowledge transfer that your HTA organizations cannot do alone. And raising the voice of a small minority is tough. It's really tough. And this quote from Malala stood out to me because type 1 is invisible, and the societal and internal stigmas naturally silence us. But when we stood together and gave our best shot for the CGM survey, we saw how loud and how important this minority voice was. So here are some ideas how you can involve patient groups and patient engagement in your HTA analyses. You can think about inviting patient groups to review your surveys, whether it's the phrasing or the answer options, thinking about what else might be important to them. You can also ask them to help you interpret or shed light on your research findings, your questions, or the uncertainties at the back of your mind, maybe some difficult questions that you didn't know how to ask, because don't be afraid, we don't bite. And if you're a policymaker or evaluator, perhaps you can also think about how can you include the non-clinical impacts of drugs and medical devices in your assessments. Because when it comes down to it, we are humans too, not just clinical outcomes or dollars on your spreadsheets. Thank you. Thank you very much. If you have any other questions outside of this webinar, you can also reach me through these means.
Thank you so much, Candy. That was so rich. We often talk about the patient voice as illuminating the data, and I think you really illuminated this discussion today. There were some points you raised there about what questions you ask. You know, in health technology assessment, we talk about perspectives and how they influence our value judgment. So we all ask different questions depending on our perspective. So patients, of course, ask these different questions. That might lead to needing different evidence and then a bit different outcome around value judgment. And you also spoke about that silent mental burden, which is something we want to hear in the patient voice, but we also need the skills, don't we, to understand how to hear that patient voice and how to listen to it. Can I throw one quick question at you? And I know the questions are flooding into the chat as well. Can I ask you, how can agencies better engage or learn from informal patient groups? Because these are the people who could be the biggest benefactors of the policy changes, but often get deprioritized due to being minorities.
And do you mean how can we suggest how the government wants to interact with us?
You know your experiences and how you function. Patient communities aren't just sitting out there waiting to answer HTA. They have all of these other things going on. How can they approach it?
I'd say that an important first step that really can't be missed out is in the first meeting, just listen. It's important to come with an open mind. And I'm saying, imagine yourself as a blank sheet of paper you are offering out to the patient group and you're inviting them to fill in. And this is important because perhaps the questions you are already working on, or the questions that perhaps even your team of experts already know much more about, may not be the things that matter to us or the things that factor in our daily lives. But when you come in and just listen, you can already spot some of the themes that come up in the way we choose to describe our experiences. And I think that is very important, because when you look at a drug or a device, you're looking at the thing on its own. But rarely does the user come in at the same time and already shares what they're concerned about, or even what their journey was like years before the current technology became available. So I would say the important step is to listen first and try not to come across like you have an agenda. Like, by the end of this meeting, I still want to find out about these 3 points. Like, just have it as a social coffee, lunch, get to know the representative or the group of representatives first. And when you have their trust, and when you ask them for things like, oh, could you introduce me to more people who are using it or people who are interested in it, you're enabling your future advocates. And I think that's what makes it sustainable.
Thanks for that, Candy. That takeaway of listening and that step towards building relationships, I think, is a really valuable for us to have on this webinar. I'm now going to go from hearing from the patient perspective back across to Taiwan, and we're going to learn about partnering with patients from the perspective of a researcher at the Division of HTA at the Center for Drug Evaluation. Welcome, Michael Wei-Chih Lu. May I hand over to you?
Okay. Hello, everyone, and good morning, good afternoons, and good evenings to our colleagues and friends across the Asia Pacific or outside of Asia Pacific. It's a real pleasure to be here today representing the Center for Drug Evaluation's Division of Health Technology Assessments. My name is Michael Liu, and I work with the patient team at HTA. I'm going to give you a quick overview of how patients are involved in the HTA process in Taiwan. So this is my disclaimer. Okay. Let's start with a look at how patient involvement has evolved in our HTA journey since 2015. We have been actively collaborating with patient representatives and groups to strengthen their engagements in the HTA process. And here is the quick timelines of key milestones. We first launched a digital platform where patients and caregivers could share their experience with new medical technologies. The next year, the patient group representative gained a voice in reappraisal committee meetings, allowing them to directly express their perspective. And 2017, we established a citizen council and developed formal guidelines to ensure consistent and meaningful patient involvement. In 2019, it became standard practice to include 2 patient representatives in all PPRS, that is the Pharmaceutical Benefit and Reimbursement Scheme Committee meetings. And to 2020 onwards, we initiated regular meetings with patient representatives and now actively incorporate patient input into HTA reports before they are presented at the PPRS meetings. Our partnerships with patients and patient groups remain a key priority as we continue to explore new ways to enhance their participations in the HTA process. Now, let's take a look at how the reimbursement process works in Taiwan. Start from the left. Manufacturers submit products for coverage to the HTAi, initiating a process of assessment and deliberations. And we in CDHTA divisions handles the health technology assessment, while an expert advisory committees make recommendations for the PPRS considerations. The final decisions rests with the PPRS committee determining coverage and reimbursement for new technology. But where does the patient voice fit in? Here is a simplified overview. During the HTA assessment, patient and the public can submit their input and experience through our online platform on the HTA website. It will be us in the CDHTA that helps summarize the patient's inputs and provide a summary presentations to the PPRS meetings and incorporated the patient input summary into the full HTA report. Our patient team organized pre-meetings with patient representatives to discuss the upcoming cases and gather their perspective. And it is us in the CDHTA who call for the meetings and make the briefing for each one of them and for each case with patient inputs collected that will be discussed in the PPRS meeting. Then the 2 patient representatives are present at every PPRS meeting to ensure the patient voice is directly heard. In the reappraisal cases, patient organizations also have a dedicated 10 minutes slot to present their views. This multifaceted approach allows us to capture valuable patient perspective throughout the reimbursement process. Now, let's zoom in on the online platform where we use to gather patient perspective. Launched in 2015, the platform serves as a dedicated space for patients, caregivers, and patient groups to share their experience and insights regarding the new medical technology under considerations. And this valuable input help us understand the real-world impact of these technologies on the lives of those affected. The CDHTA team plays a crucial role in analyzing and synthesizing the information gathered through the platforms. We carefully review the submissions, identify key themes and concerns, and prepare concise summaries to present to the PPRS committee. And this ensures that the patient voice is effectively integrated into the decision-making process. Our latest platform updates features a refined question design to capture in-depth perspective from patients and caregivers on disease management and new treatments. And these are the questions aimed to understand the real-world impact of these technology on their lives. For example, like how have you gathered the information about your condition and treatment options? Because it is not only patients, but some patient organizations or like caregivers could also log in the system to reply. The second question goes, how does your disease or condition affect your daily life or the life of the family? And the third question is, if you haven't used this medication, new treatments, what is your current treatment and how well is it working? Have you experienced any side effects or challenges? The next question goes, what are your hope and expectations for these new treatments? What improvements in your condition, side effect, or quality of life are you hoping for? The next question is, if you have used the new medications, how effective has it been for you? Have you experienced any side effects? How does it impact your daily life or the life of your family? And question for caregiver, how have the patient's condition and treatment affected your daily life? The last questions say, is there any else related to your disease or treatment that you would like to share? Now, let me present a case study that highlights the challenges and opportunities in providing access to new medications for spinal muscular atrophy, SMA, in Taiwan. As you know, SMA is a genetic disease that affects the muscle and nerve system, and leading to muscle weakness and progressive disabilities. And in recent years, there has been significant advancement in the SMA treatments and several new therapies emerging. For example, the first SMA drugs by Spiraza, approved by the US FDA in the 2016, and Evrysdi, and oral medications for SMA offered a more convenient dosage form. And more recently approved in 2019, the Zolgensma became the first gene replacement therapy for SMA. This breakthrough brought new hope for patients with SMA in Taiwan who eagerly anticipated access to those potentially life-changing treatments. However, the path to reimbursements under our national health insurance system is often complex and time-consuming. Several factors contribute to this, for example, like the evidence uncertainty and also the huge budget impact. And due to this complexity, reimbursement decisions for new medications often involve extensive deliberations and may require multiple rounds of review before a conclusion is reached. Usually, it will start with the reimbursement restrictions, and later it will be discussed to expand its indications or to a broader populations to use. Let's see this process in action with a real-world example. This is a screenshot from the presentations given by a patient group representative during a PBRS meetings in early 2023. As I mentioned earlier, when a case is being discussed at the PBRS meeting, patient group were given the opportunities to present their perspective directly to the committee. And this case perfectly illustrates how patients are actively participating and influencing the decision-making process. This representative made the presentation named Ms. Li Yijie, the president of the Become the Miracle Association, a leading SMA advocacy group in Taiwan. She is also a patient with severe SMA, delivered a compelling 7-minute video presentation sharing her personal experience and advocating for access to broader populations of patients with new SMA treatments. In her presentations to the PBRS committee, Ms. Li shared a powerful video showcasing the transformative impact of SMA medications. The video vividly illustrated the difference in the children patients' ability before and after the treatments, providing compelling patient-provided evidence of its effectiveness. This visual testimony allowed the committee members to witness firsthand the real-world benefit of the medications, going beyond the clinical and the statistics. It personalized the impact of the treatments, reminding everyone of the human stakes involved in their decision. Not only that, to ensure the patient voice is fully considered, the HTA patient team play a active role in every PBRS meetings where patient input is relevant. Here is how we do it. We gathered all patients' inputs received through our online platform, and the input is then summarized in the presentation slides, like I'm showing you now for the PBRS committee members. In overall, into 4 dimensions: current medical states, user experience, quality of life, and expectations to the new treatment, and incorporated into the 4 HTA reports prepared by our researcher. Following the presentations and a thorough discussions among the committee members, both SMA cases were ultimately approved for the reimbursements. Although the meeting minutes, which I'm showing you, are in traditional Chinese, I can confirm that the committee reached a positive decisions on 2 important cases. Spinraza, the committee re-evaluated the existing reimbursement policy for Spinraza and expanded its coverage. In the second case, Evrysdi, the oral SMA medication, received its first approval for reimbursement, providing a new treatment option for patients. These successful outcomes highlight the effectiveness of incorporating patients' perspective into the HTA and reimbursement process. The patient's presentations, combined with the comprehensive HTA report and also the committee deliberations, led to expanded access to vital SMA treatments for patients in Taiwan. To ensure transparency and accountability, the PBRS meetings are fully recorded, and the minutes, along with the audio recordings, are made publicly accessible on the HTAi website for after each meeting. And in addition, for those cases that are approved for reimbursement, the 4 HTA reports are also published on the CDE website. This allows for public scrutiny and contributes to a more informed understanding of the decision-making process. These commitments to openness reflects our dedications to patient-centered healthcare and strengthens trust in the HTA and reimbursement system. To conclude this case study, I want to leave you with these 2 quotes from Ms. Lee's presentations to the PBRS committee. The first quote was, "To be no burdens justify just this tiny wish, only treatment can grant it." This statement speaks to the profound impact that SMA has on patients' life and their desire for independence and a better quality of life. And it highlights the transformative potential of treatments and the hope it offers. The second quote said, "The 200 SMA patients are still waiting for these life-saving medications. We will not give up on any one of them." These quotes underscore the urgency of the situations and the unwavering commitment of patients advocates to fight for access to treatments for all those affected by SMA. It serves as a powerful reminder of the human stakes involved in the healthcare decisions. And this will powerfully illustrated the importance of patient voice in the HTA and reimbursement process. They remind us that behind the data and deliberations are real people whose lives are profoundly affected by the decision we make. Well, before I close, I would like to express my sincere gratitude to the entire CDHTA team, especially to Dr. Grace Wan and also the patient team led by our section chief, Stephen Lai, and my senior, Kathy Gong and Amanda Su. And of course, our founder, the Ministry of Health and Welfare and the National Health Insurance Administration. This is my last PowerPoint slides. So, some key highlights. The patient input are now, patient input are now systematically into the HTA report, ensuring that the patient voice is heard in the decision-making process. And we have expanded the decision-making process. We have expanded the opportunity for patients to share their perspective, increasing their influence on the HTA outcome. And also we have the regular pre-meetings before the PBRS meetings, foster better communications and understanding among all stakeholders. We also host communications meetings to facilitate educational events and learn together with our patient group, and patient representative. As for this year, we have held the meetings learning from Canadian patients' deliberation process. And also we introduced for the first time the summary of information for patient, SIP, as a tool for incorporate beta patients' inputs. Thank you very much. And I hand back to the moderator.
Thank you very much, Michael. And it's lovely actually to see some of the CDE team there in the room with you today. Can I ask you one quick question? The question is, how does the patient opinion platform enhance the overall HTA process in Taiwan?
Well, as I mentioned, that the patient opinion platforms was launched by the HTAi, allow not only the patients, but the caregivers or the patients group to provide input on the drug and medical devices, particularly for the catastrophic diseases. And this platform facilitates the collections of real world experience and expectations, which are critical for us to understand the broader impact of health technologies. And by integrating this feedback into the HTA reports, during the process become more patient-centered and leading to a more informed and balanced decision-making.
Oh, more informed and balanced decision-making. Thank you. Thank you, Michael. I really appreciate it. Now, an update on our time. We had so many great case studies. We did try to squeeze perhaps a tiny little bit too much into this session, but we have one more great case study coming up. So what I want to let you know is that do keep your questions going in the chat box, and we will endeavour to answer them all. We may run slightly over time, and I do apologise for that. And I want to share that HTAi's and HTAsiaLink's webinars are available on the HTAi YouTube channel. So you can watch the recording if you miss the end of this. And of course, reach out to us if you want to follow up and ask any further questions. But with that, I would like to hand over to Eric Liu. So sometimes patient representatives are members of HTA committees and panels, and that's what we want to focus in on this final case study. So can I introduce Eric Liu, who's Vice Chairman of the Taiwan Young Patients Association.
Thank you, Anne, for your introduction. And I'm Eric from Taiwan Young Patient Association. And let me just share my slides. Okay, can you see my slides?
Perfect, thanks.
Okay, so let me make a quick introduction. I'm the Vice President and co-founder of Taiwan Young Patient Association, and then I'm the patient representative in Pharmaceutical Benefit and Reimbursement Scheme Joint Committee as well, which is PBRS that Michael was mentioned earlier. And I'm the members of some of the committees in Legislative Yuan, which is the Congress in Taiwan. So, okay. And I will make a quick introduction of the reimbursement process, but as Michael just introduced, I think I have some patient's view to this this process, and so maybe my comments will be a little bit different from HTA's perspective, but just let me quick introduce. So once the pharmaceutical company apply for this reimbursement, the HTA will the CDE HTA team will make this HTA report, and on the patient opinion sharing platform will ask patients and the public to share their opinions, which is the same platform Michael just shared. And I've heard the discussion of how does this platform works. I think there is some barriers for patients and patient representatives to share opinions. Is that actually in Taiwan, before the new drug is reimbursed by national health insurance, we have to use these medications out of pocket. But for patient groups, we hardly can reach to those patients who are using these drugs out of pocket. So it's quite difficult for us to get information from patients who have the experience of using these drugs. So it's quite a little bit it's quite a little barrier for us to really provide I think meaningful experience or opinions on this platform and during this process. So I think there is still something we can do more to collect patient opinions. So okay, so this is a little bit a challenge we are facing right now in patient groups. And after the opinions are collected, these opinions will be added into the HTA report, and these are some notes that the HTA report will firstly provide to the expert advisory committee here, but there is no patient representatives sitting in this expert advisory committee, which is a closed-door meeting. And where does these patients' opinions go? These opinions will be added into the HTA report after the expert advisory committee has some conclusion. So patients' opinions won't be discussed in this advisory committee. However, this committee they usually decide they usually decide whether this drug can be reimbursed or not into the next discussion. So as we can see, after the discussion of expert advisory committee, patient's opinion will be handed over to PBRS, and in PBRS, this is the members of PBRS. So we can see there are 30 formal members and then 5 in attendance members. And patient representatives are in attendance. We are not formal members. So what we can do is basically we can observe the meeting, and then we can make some meetings record. And of course, if we have some comments to certain cases, then we can ask the chairman for permission to speak, but we don't have the power to decide whether the case should be approved or not. So this is basically the reimbursement review process. So as I just shared, that patients has we have limited influence to whether to the review result. So what can patient representatives do in the process? Oh, sorry, we can see before PBRS, we can collect patients' experiences and opinions. And in PBRS, we can attend the meeting, but we don't have the power to decide the results. And patient opinions are listed in HTA report, but not discussed in expert advisory committee. And the patient representatives can ask for permission to share opinions. And after PBRS, we will share the meeting records to Taiwan Alliance of Patients organizations, where the patients organizations gathered. And because there are many different of disease and many different kind of treatments that different organizations are concerned about. So so we patient representatives will have to share these records to those who are concerned. And then after the meeting, the HTAi will announce the audio record and paper reports on official website. So as we can see, patients representatives have limited influence to the results. So what else can we do? This is a study by Taiwan National Health Insurance Society in 2013. They want to see what do stakeholders value most in assessing new drug reimbursement. So we can see there are different parties, government, medical experts, non-medical experts, consumers, and hospital. And as we can see, for government and hospital representatives, they value budget impact most because they have to allocate the resource of national health insurance. And however, for medical experts and consumers, we value the severity of the disease most. So basically, we're standing from the patient's needs and the public's needs. And so what we can do is there are some pressure points we can do to influence the results, but not in the official process. So what we are doing outside the official process is we did some patient and disease research. What we did is like breast cancer patients, qualitative research, and we did the lung cancer patients unmet need survey. And then we held a lot of press conference and forum to share the patients' opinions with the government. And then we visit a lot of legislators and politicians to raise our voice to a higher level, and including our vice president and who is the president now in Taiwan. So we think patient representatives should get more involved in the process, and including the expert advisory committee, we think we should include patient opinions into discussion, not just listed in the HTA report. And as for PBRS, we think patient representatives should be formal member. And I know we have a lot of expectations of involving into the process, but we also do have among patient organizations, we do discuss what we have to do to what abilities we should acquire. So I think the most important things is, the first thing is to know the system better, because not all the patient organizations or patient representatives know how this system works. And the second thing is patient data collection and analyze. I think evidence-based discussion or evidence-based advocacy is now what our governments value most. And I think we are here to solve problems together. So with more evidence and more solution, then we can discuss more. We can help patients more with our decision making. So I will leave my sharing in this last question is, what kind of patient reports can help decision making better? This is what we are trying to find out, and we hope we can help this decision making become more patient friendly and can meet more patient expectations. Okay, so thank you. This is all my sharing.
Oh, thank you so much, Eric. It's been terrific having these presentations which give us inside the HTA agencies and then the patient perspectives. Being a patient representative in HTA always seems to be an incredibly demanding and hard job. And I'm conscious that HTAi actually now in its patient and citizens interest group has patient representatives from these committees and from consumer members and HTA lay members. meeting together now and sharing practice. I wondered, could I ask you a quick question? If you were giving an HTA agency tips on involving patient representatives such as yourself, are there some things they can do that would make it easier for patient representatives?
Okay, I think the first thing is education program. I think most of the patient representatives need to learn more from how to evaluate how the system is evaluating the new drugs or new health technology. And I think the second thing is we should know what kind of data or what kind of patients of perspectives can help decision making. Because I think sometimes what patients value is not what the decision makers value. So how can we meet the values? It's very important. So I think we need more conversations and to discuss what we all concerned about. And then I think the last thing is maybe there should be maybe some template to tell us how to collect the meaningful data for decision making. Because I think there are already some templates for collecting patient opinions right now on the platform, but I don't think the decision makers are reading them. So I think maybe those information is not helping them to discuss, or maybe those are not the value they want. So maybe we can discuss more and to find out what patients' view can really influence to the review process.
Oh, thanks for that, Eric. There's some great tips in there, and it's great to have these different perspectives. Now, for those of you who've been good enough to stay online, appreciate your time. I'm going to throw one last poll up, Nicola, if we can bring it up. We just wanted to ask you one last question before you go. And this one's for all of you. And so this question is a chance for you to say, out of these options, what do you think about patient involvement in HTA? So you can say patient involvement in HTA is not important, is useful in some assessments, is important in all aspects to learn from patient knowledge, in all assessments to learn from patient knowledge and perspectives, or you're not sure. So we'd love your last votes. While you're doing that, I see a hand is up. Sawa Kenji, please correct my mispronunciation of your name. Would you like to ask a question quickly before we conclude? I'm not sure whether maybe it's easy to bump the button. So if you didn't mean to have it up, you can always ask the question in the open and in the Q&A, and you always feel free to reach out to us afterwards. Okay, that's a really interesting outcome. Thank you for that. That answers to the polls. I'm pleased to find that no one today has suggested it's not important. Just as we conclude, I want to raise Fiona, if you're able to share the slide about some work going on in HTAi Patient and Citizens Interest Group. It's not showing up properly at the moment, Fiona. There it is. It's just showing on project audience. So there is work going on which Fiona and I are leading, which is about to start, where we're going to co-design a project to complete a landscape analysis to document existing patient involvement practices in HTA in the Asia-Pacific region, so beyond Asia, including the Pacific, and develop recommendations for supporting and strengthening patient involvement in the region. And specifically, we're going to look to provide a living document on the status of patient involvement in the region that anyone can access. We're going to support patient involvement in the region by identifying actions to support and strengthen existing and new processes. And we hope it will also develop and strengthen networks across this region. So if you're interested in more in that, you can always reach out to HTAi. We'd love to hear from you. It's been a terrific chance to hear the work across the region. It's rich, this region, with experiences. As you can see, we even struggled to fit them all into this session. Can I thank our really exceptional speakers tonight? Thank you all for those presentations and also for all the work to answer questions. You will find the recording of these sessions will go onto the HTAi YouTube channel, and we'll also pick up any unanswered questions. I can see there's one there now. Thank you to Nicola in the HTAi Secretariat for keeping it all running so smoothly. If you want to find other HTAi events, you can go to HTAi.org, click on events, and you can see we've got a whole series of webinars coming up. And finally, a huge thank you to HTAsiaLink, our wonderful MOU partners who we value in sharing knowledge and collaboration about HTA across Asia. Thanks for your time today, and we hope we'll see you for another webinar.